IAPMR SVNIRTAR in association with Association of Physical Medicine Rehabilitation of Odisha and Indian Association of Physical Medicine Rehabilitation. So today we have a very interesting topic for discussion, that is how to approach clinically a patient with arthritis. In our OPD practice, almost every OPD day we get around more than 25% of patients with some form of arthritis or some form of joint pain. So as per history or clinical examination, we can classify them like monoarthritis, polyarthritis, oligoarthritis, inflammatory or non-inflammatory causes. Suppose whenever you are getting a case of monoarthritis, invariably, if it is an adult person, we say it is osteoarthritis without going in detail. And polyarthritis, we always look for any clinical criteria whether it's fitting to it or not. So due to some of our ignorance, many times we misdiagnose the condition. We sometimes go for mild treatment also. Like many polyarthritis conditions, they present as an acute monoarthritis. For example, a case of patient with family history of psoriasis can even present with monoarthritis. Inflammatory bowel disease can also present as monoarthritis. 20% cases of rheumatoid arthritis start with acute knee pain. And some spondyloarthropathy or sarcoidosis also, even they sometimes present as a monoarthritis. So even some cases of large joint involvement like hip, shoulder, many times you confuse. So it may be sometimes because of polymyalgia rheumatic or part of spondyloarthritis. So it's a very large field, and because of that lack of clinical exposure, lack of clinical acumen for analyzing the condition, many times we misdiagnose it. So today we have with us one of the very well-known rheumatologist with us. Is from Odisha. He is Professor Dr. Jyoti Ranjan Parida. He is a well-known rheumatologist of Odisha. He is now currently working as medical director and consultant rheumatologist, Odisha Arthritis and Rheumatology Center. Professor Jyoti Ranjan Parida has a good clinical and academic career. He has completed, he has done his DM in rheumatology from prestigious Institute of SGPGIM, Lucknow, and he has got also gold medal in his DM. And he has a lot of contribution in patient service field, especially clinical field. He has got Professor R.K. Sharma Best Clinician Award in 2014. And he has done fellowship, Indo-UK fellowship in 2014, Nottingham's UK. And he has also done post-graduation diploma in musculoskeletal ultrasound from Spain. He had more than 15 publications, research publications. He has 2 books to his credit. I am diagnosed as lupus and my child is in pain. Odisha, he has also got Odisha Youth Icon Award 2016. So we are very proud that we have with us a very experienced rheumatologist who can share his experience with us, and he will guide us that whenever a patient comes to us in a OPD with some form of joint pain, how we will proceed clinically, how we will come to a clinical diagnosis, clinical conclusion, and how you decide that what type of investigation should follow to come to a diagnosis. Let us welcome Professor Dr. Jyoti Ranjan Parida for presenting a talk. Welcome you, Dr. Parida.
So thank you, sir. Good evening to all, and particularly thanks to IAPMR and in particular the whole organizers for arranging this webinar and inviting me. And thanks to Dr. Pavitra Sahoo sir, who is behind me for the last 1 month for this webinar. And this is something, a topic also very close to my heart, because we'll discuss all along why this is so important nowadays to have a very, very clinical approach, not only for the rheumatologist, for every physician, for every orthopedician, for every general practitioner, and persons involved in arthritis care, like all rehab doctors, all physiotherapy doctors, and so on. Anybody who comes across these patients at any point of their illness should be very thorough, that how clinically with certain anticipation or certain calculation we can know that what exactly is the type of arthritis, because if you not treat them in time, the result can be disastrous. And simultaneously, if you over-treat them, the results will be disastrous, because all this treatment, you should not give punishment to anybody who is not guilty, all punished should be, all guilty should get punishment. Like that, if you over-treat or under-treat, then the result is going to be very, very disastrous. So again, welcome all for this webinar. I think my slides are visible now.
Yes, yes, it's
Okay.
visible.
So let's discuss how to clinically approach a patient with arthritis. Why this is important, why I am talking of this is a very recent photograph I have taken in my clinic. That you can see every day in our OPD, we see an old man carrying his wife in a stretcher or in a wheelchair. And if you very closely look at the hands, it's terrible. The whole hand got deformed. There is no movement at all the joints, there is no function. So why this, and all these things are actually at one point of time of the disease was reversible, because for the last 15 years, nobody has diagnosed correctly, nobody has treated her correctly. Now she's in a position that at her old age, she's dependent on others. She's not able to feed herself for any day-to-day activities. She's dependent on the whole family. So arthritis is again not a burden to only the person who is suffering, it is also a burden to the society or the family, whole family, both financially and emotionally. It is not only about old persons. You see, these are the pictures taken in my clinic. All these are very young patients who are having a very good, who are in their teens, actually, who are in their very young phase of life, but all of them are suffering from a disease called as ankylosing spondylitis. And because again, nobody has diagnosed them correctly in the early part of the disease or not provided the correct treatment, now they are in this state that they are dependent on their family. They have lost all their hopes of careers, career dreams, marriage, and so on. So arthritis nowadays, we know that it can affect beyond the age groups. It can be from the child to adults to old age, and it can, if not treated in time, it doesn't kill you, but it kills the aspirations, it kills the dream, it kills the expectations of the whole family, and it can really take the whole family a decade back or 20 years back. So why there is a problem? Because whenever, usually this is our traditional approach, that when somebody comes to us that doctor, I'm having this joint pain, then for years together we have taken that very casually, and it's very simple. We just label them as rheumatism, and we order them few blood tests, because we all have a concept that rheumatism or this arthritis is usually detected or diagnosed from the blood test. So what we do when we see any musculoskeletal pain, immediately we label them as rheumatism or polyarthralgia. We order a battery of tests, and the most famous test, all of us know, that ESR, CRP, rheumatoid factor, uric acid, ASO, etc. And obviously, if we'll send so many tests to any person, so many times we have seen some of them will come positive, 2, 3, and 4, and some of them will be negative. And based on this data, usually we start our therapeutic trials. So diagnosis and treatment made very easy. That if your ESR, CRP are high, you tell the patient that, okay, this patient is having arthritis. You give some painkiller, you start with naproxen, diclofenac, as per your individual choice. If the rheumatoid factor is positive, then usually people have a tendency to call them as rheumatoid arthritis without examining that exactly what is the clinical pattern. And then immediately the prescription contains methotrexate, sulfasalazine, etc. If the uric acid is high, I can tell you that so many cases of asymptomatic hyperuricemia who doesn't require any treatment. But if the uric acid is high, usually we label them as gout, and then we start giving them febuxostat and so on. If the ASO is high, again, which is very, very common, anybody having a throat pain, you send ASO, it will be positive, and immediately the patient is prescribed with pain-induced injection or nowadays pented tablet. And if a particular patient has more number of positive tests, like patient is having also rheumatoid factor positive, also uric acid high, whatever diagnosis you may write, you try to prescribe more and more tablets to cover all of them, and in that process, the patient land in problem. So I am going to share the true story of this 20-year-old male. I have just got the prescription so that the identification will not be visible, but the whole aim being that this is the usual practice. Most of the time we see in our day-to-day practice that this is a patient of 20-year-old male who most probably has complained of fleeting polyarthritis in 31st/8/2015. And left side you can see within the advice box or the green box, so many tests has been advised, and because many of them have come positive, so this patient was labeled as fleeting polyarthritis and was given with febuxostat, Tide Plus, and Meproxy, which is a steroid. Again, because there is some swelling, you give some diuretic, and again, because the uric acid is high, you have given somebody has given febuxostat. But if somebody is having uric acid high, you are again giving a diuretic, which is Tide Plus, which again will cause the high increase in uric acid level. And if this is a tenosynovitis, no Tide Plus or no Lasix is going to help this patient. So after some days, the same patient had come, most probably with more pain. Again, Dexona injection has been given. Next, there is no relief. Again, the treatment, the dose was high. Again, after 2 months, you can see in the right-hand side prescription, it was 25th October 2015. Then more number of medicines have been advised. Then you can see the prescription of 2011 of November 2015. The dose of methylprednisolone was high, and then because the ASO was high and nothing is working, somebody has prescribed penindiol. But still the patient is not improving. So the patient was labeled as seronegative rheumatoid arthritis. Most of the rheumatoid factor was negative. And then patient started with the HCQS, Donica, Folitrax, etc. And finally, you can see the number 3 medicine, that is all favorites, and you can tell that that is a Brahmastra for arthritis. So finally, patient was prescribed with Omnacotil 40 milligram after breakfast and 20 milligram after dinner for 60 milligram of Omnacotil for 1 month. This is our sheer desperation because the patient is not improving. And read our desperation on the patient face. When the patient came to our OPD, patient is still the arthritis is there, but patient is having a moon face. Patient is having all the side effects of steroid side effects, hirsutism, moon face, and so I really wonder how they are related. You can see this is a prescription. I have taken it from one of the case records of a OPD patient that uric acid, anti-nuclear antibody, ASO, and rheumatoid factor, everything has been advised to the same patient. That means there is no thought before we prescribe or before we advise our test, because if you will not narrow down your possibilities from your clinical judgment, then obviously you are going to get this kind of reports, and you are unnecessary, which have a huge financial implication for the patient itself. And finally, it gives a lot of confusion than clarity that if 2 or 3 of them will come positive, then you are nowhere. So after sending a lot of tests, and if still the patient is not improving, you have given everything, including your final weapon, that is steroid 1 milligram per kg body weight. Then what we do is we scratch our head, and then we think that most probably allopathy is not great for arthritis. So patients roam around, because patient will come to you for 2-3 times or 4 times, because this is a chronic situation. You have a lot of pain. If you can't solve, or if you don't have any idea what the patient is going through, and if you only chase the investigation reports, then the patient usually thinks that allopathy is not great. So patients go, somebody advised that why you are not trying alternative medicines. And sometimes patient go after this mirage of cure, what I call as a 1 month guarantee that, okay, everything will be all right. You stop eating this, stop eating that, take this medicine, take that medicine. These are some prescriptions that I have collected that, again, there is a lot of restriction that you should not take bath, you should avoid cold, you should avoid, like you can read that gadeiba, puchiaba, thondaba, nisa, ghio, luna, telachana, pachla kadali. Today in 2022, I think there is a very, there is no scientific evidence actually to prove these associations. And we have seen a lot of patients who are actually really diagnosed well, treated from very early age. They can actually eat everything and anything, and still they can have a better outcome. And many patients who have through very stringent dietary control, but they have no improvement because they have not got the proper treatment. This is the height actually, because I have seen this advertisement in the Telegraph on 23rd January 2016, which was the birth anniversary of Netaji Subhash Chandra Bose. So when I came through this article that you give me time, I will give you freedom from joint pain. And very curiously, when I have gone through the article, then what I have seen that this is the advertisement of a Center for Advanced Pain Solution, which is a combination of homeopathy, Ayurveda, Unani and Physio. And what they have claimed that you give me blood, I will give you freedom from joint pain. Okay. So where we went wrong actually, why these things are happening, even in every field. I'll not tell this is, I think this is on every field, because particularly because I am a MBBS graduate, so I know that how much time we have spent in our curriculum in locomotor system or in musculoskeletal system. So this was the least priority than dissecting a heart murmur. When we are third year students, fourth year students, when we used to go to clinic or attend hospital patients, the first thing that usually being told by our teachers also was very fascinating, that whether we are able to listen and diagnose a murmur of mitral stenosis, a murmur of mitral regurgitation. But I'll tell you, after advent of echocardiogram, I have seen many times in my MD career that whatever you listen up, so many times your auscultatory finding may not be matching with the echo finding. But at the same time, we give very less time in our curriculum to how to deal with patients with arthritis or musculoskeletal system. When we become doctors, whether we practice as a plain MBBS or with a super specialty degree or a specialty degree, all of us have come across more patients with this musculoskeletal system rather than patients with these cardiac murmurs. So we even as doctors don't know who should deal with arthritis. So many times I have heard from my patients that some orthopedic doctor has told them that, okay, you can try alternative medicines because I am not able to identify that what disease you are having or you are not improving. We rely heavily on microscope or blood test than the stethoscope or our clinical acumen. And we don't realize, actually, that is very important. We don't realize the importance of a loose or false diagnosis. Like if I today write somebody as rheumatoid arthritis based only on rheumatoid factor positivity, this has a huge implication for the rest of the life for the patient, because I'm going to try with immunosuppressive medicines. I'm going to try with one after another medicines which need stringent blood monitoring. So which has again a very high financial, emotional, physical impact on the patient's life. And we have less empathy to an arthritis patient than a DCM patient, dilated cardiomyopathy patient. Although we know that for a dilated cardiomyopathy patient, we can do very less. But when we see a arthritis patient, we just try to ignore. Okay, just give some painkiller, wait for some time. But here I'll tell you, early intervention in the course of arthritis can actually make a huge difference than treating a DCM patient. So before treating, we have to clear these myths, not only among the patients, also among the doctors, that there is no treatment in allopathy. Alternative medicines can cure so-called rheumatism. Lab tests are the only way to diagnose arthritis. Only treatment, because nowadays also most of the feeling that why patient doesn't come to allopathy, that they feel that okay, these doctors are there who only knows how to prescribe steroid or painkillers, which are supposed to be very potential villains, and you will get allopathy over a year, you will develop liver injury or kidney injury or a gastric injury. And these drugs that you prescribe like methotrexate or leflunomide or cyclophosphamide, then patient will go to internet and they'll find that okay, these are the drugs that are used in the treatment of cancer, so better to take it at very minimal dose. I always tell that we prescribe, the chemist decide. Actually, even if the patient come to us after doing so much of research, once you write a medicine, that they always feel it very comfortable and convenient to discuss with their nearby chemist. If the chemist will tell that don't take methotrexate 15 milligram, this can be dangerous, you take 7.5 milligram in a low dose, then the patient accept their version very well than the doctor's prescription. So I always tell that we prescribe, they decide, or the chemist actually decide what dose to be taken by the patient. And patient feel that even if you treat or not treat, the deformities and crippling is inevitable, which is not true in today's world. So why we fell upon? Because again, we all are confused at whom to consult, physician, GP, whether to go to Olatpur, whether to go to a rheumatology center, whether to go a orthopedic center, at what point of the time, where to go. What we are treating actually, so many times as doctors I have seen, patient tells pain near the elbow, pain near the shoulder, and to that myofascial pain, because I think you all people are very well versed that and must be seeing every day that so many myofascial pain, so many patients with fibromyalgia, so many patients with trigger finger, so many patients with tennis elbow, they are being treated as arthritis, and that's why they are not improving. Which test to order, with what to treat, how long to treat. All these things are important, because you will understand two very important concepts in treating inflammatory arthritis. That is window of opportunity. All these patients of inflammatory arthritis will give time to us within 1 to 2 years of their initial diagnosis or the symptom onset. If this is the time, if you treat them well, if you treat to target, like any other chronic disease, like in diabetes, you treat the patient so that the HbA1c should be less than 6.5. Doesn't matter whether you are giving insulin, you are giving oral hypoglycemic agent, but if the target HbA1c level will be less than 6.5, then the patient is not going to have complications. If you are treating a patient of hypertension, there is a target that only getting treatment. I have seen so many patients, the blood pressure is 180 by 90. Why you are not taking the blood pressure tablet? Sir, I am taking blood pressure tablet, I am under treatment, but I have not visited a doctor since last 2 years. I have gone once, the doctor has given some medicine, I am taking it for hypertension. So only getting treatment doesn't solve the purpose. Whatever chronic disease you are treating, there should be a target to treat. Like any inflammatory disease, arthritis, if you are treating, you have to treat to a target that there should not be any tender joint, there should not be any swollen joint. The ESR CRP should be within control, so that we can tell that the patient is in remission or very low disease activity, so that the disease progression will not be there and there will be no deformity. If you are only treating for the treatment's sake, but the patient disease is progressive, the inflammation is going on, then there is no point in treating, because anyhow the patient is going to land in deformity and crippling. And window of opportunity, obviously, first 2-3 years, there is a scope of reversibility. We have to target that part. So in reality, a MBBS doctor sees more joint pain than heart pain. So there should be more, actually this approach discussion, algorithm discussions should be in our MBBS curriculum, which is very sadly not there. Addressing joint pain, if you were trained nicely during your MBBS days, that is very easy than managing angina. It requires very less lab tests. Actually, most of the puzzles, more than 90% of the patients can be treated, can be diagnosed without doing a single blood test. And for a particular peripheral setup where blood tests are not that easily available, or the quality of the tests are not that good, or the patient cannot afford, this is a disease. Arthritis is a disease. If you treat them, if you diagnose them, if you know how to diagnose them, I think this will give you more satisfaction. This patient will have more benefit than treating any other disease in medical science, because most of them can be diagnosed clinically and treated accordingly. So if diagnosed and treated properly, treating arthritis can be really rewarding. So what we lack is a correct clinical approach. That's why I am so glad that when Dr. Sahoo has approached me, that we'll discuss about how to clinically approach a patient with arthritis. I immediately agreed, because this is what actually we should all discuss every day in and day out. So rheumatology is nothing rocket science actually, because most diagnosis, if you spend 10 minutes to the patient bedside, I think most diagnoses can be made with perfection. Only you test lab investigations to exclude some diagnosis. Like if you have a patient of polyarthritis, clinically this is looking like rheumatoid arthritis, but if it is a young girl, if the urine is showing proteinuria, then you have to do a ANA to exclude that whether this patient is having SLE or not. Prognostication of the disease, like if the ESR and CRP are not getting controlled, then most probably the patient is going to land in complications. If there is a very anti-CCP is very high, most probably this disease, this patient needs very aggressive treatment, because anti-CCP and rheumatoid factor has less diagnostic importance, more prognostic importance. And obviously confirmation of the diagnosis. Once you are publishing a paper, or once you are giving some biological therapy or some advanced therapy, a baseline confirmation of the diagnosis is required. But starting treatment in most of these patients, diagnosing them, it only needs a step-by-step approach, and only by history, 80% of the things can be solved. That, like Dr. Sahoo was highlighting during our introduction session, that if it is a polyarthritis, or it's a monoarthritis, or it's a oligoarthritis, whether it's a acute onset arthritis, whether it's a chronic arthritis, whether this is a episodic arthritis, or whether this is a migratory arthritis, those things it will go step by step. Then 95% cases, and then you examine whether there is a true arthritis, or it is a simple myofascial pain which you think as arthritis. Then I think 90%, 95% of the problem can be solved. And in a community perspective, if you see the regular OPD in a PHC, only 10% of them are actually inflammatory arthritis. 90% of them can be filtered out at a PHC level, and the unnecessary burden on a rheumatology clinic or a tertiary care setup can be decreased if we are very thorough enough how to approach clinically a patient, or how to take the history, do a physical examination. So like I was discussing the steps, I have pointed out that there are 10 steps to glory, or for the 10 steps, any patient with arthritis will follow these 10 steps. I think obviously 90% cases will be succeeded in getting the diagnosis. First is source of pain. If somebody is telling you that, sir, I am having elbow pain, please don't go by the word of the patient and don't accept it that this is elbow arthritis. Tennis elbow is 90% more prevalent than any elbow arthritis, which is very, 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 very rare. So if somebody is telling that there is elbow pain, please examine, please go and ask that which side of the elbow there is pain, whether there is a muscular pain, whether there is a tenderness near or what we call as periarthritis, or you should be able to know where to check for joint diffusion and swelling, which is I think which is between your olecranon and your lateral epicondyle. So if there is a medial epicondyle pain or lateral epicondyle pain, these are not tennis elbow. If there is a mid-trapezius pain, this is not spondylitis. This is trigger finger. This is trigger point or your myofascial pain. So these things is very important. Don't go by the word of the patient, which unfortunately most of our colleagues in their busy OPD they do. They just, if the patient tells the pain, where are you getting pain? If the patient tells there is a neck pain, there is a hip pain, there is a elbow pain, there is a shoulder pain, Usually we go on writing that shoulder arthritis, wrist arthritis. They are not true. Number two is, even if the source is joint, whether this is polyarthritis or polyarthralgia, because so many times the patient tells us that there is pain in the small joints of hand. But if there is no swelling of these joints, please be very careful before diagnosing that as rheumatoid arthritis. Many of these fibromyalgia, many of these somatoform disorder, they can have joint pain, but there will be no swelling or symptoms of inflammation. So whenever somebody is telling that there is joint pain or the source is the joint, please assess whether there are telltale signs or more objective signs of arthritis, which is swelling, loss of function. If the patient is not able to move the wrist or move the finger, then okay, there may be a problem in the joint itself. But if there is no swelling, no loss of movement, you have to be very careful before committing that this is arthritis. Number three, if it is arthritis, number three step is to know that whether this is a mechanical pain or mechanical arthritis like degenerative arthritis like osteoarthritis, or this is an inflammatory arthritis. Because many a time I have seen the first carpometacarpal joint osteoarthritis so common, but because this is in the hand joints and there may be some swelling or there may be some subluxation which is misread as swelling, so many times they are written as rheumatoid arthritis. So you have to be very careful that whether the pain is, what are the features of inflammation, that whether this patient is having early morning stiffness more than 1 hour or not, whether this is the pain is improving after rest or it is getting more worse after rest. So any inflammatory pain should, the early morning stiffness should be more than 1 hour. The pain should be more after taking rest, because there is a time for all the inflammatory fluid to accumulate inside the joint. And once you do exercise, when you start moving the joint, the pain is going to reduce. That is what is the inflammatory pain. Night pain is more probably is going to be inflammatory pain. Whereas when you start moving, you start doing work, and you are getting pain, which is getting relaxed or relieved by taking this, that is what is a mechanical pain. And if it is an inflammatory pain, the fourth question comes, what is the duration of the complaint? If it is a very acute pain, all of you must have come across patients after this COVID episode, whether after taking a vaccine or whether after getting the infection. Many patients came with a pain, typical inflammatory pain, but they usually fade away within weeks. So any chronic arthritis like rheumatoid arthritis or SLE or psoriatic arthritis, before committing that this is a chronic arthritis, which is a lifelong arthritis, which you have to plan accordingly and treat the patient for a very long time, you have to see that what is the duration of the complaint. If the patient is having a very short acute pain, it is only of 2 days, 5 days, 10 days, please don't jump into diagnosis, because all chronic pain will have an acute onset, like all rheumatoid arthritis patients of 2 year duration will 2 years back have started with a 10 days pain or 5 days pain. I'm not telling that 5 days pain cannot be rheumatoid arthritis, but you have to be slowly and gradually following the patient over time to see that this is a persistent arthritis. So usually less than 4 weeks pain is which resolved by 4 weeks is what we call a viral arthritis or a infection related arthritis. But if it stays more than 6 weeks, most probably this is a chronic arthritis. Then number of joints involved. Fifth, step number 5, number of joint involved. If it is a monoarthritis, like we're discussing, the most first thing it goes, whether this is osteoarthritis or there is a traumatic arthritis, whether it's an infective arthritis, whether this is a monoarticular beginning of a polyarticular disease, like it could be gout, it could be what we call as atypical rheumatoid arthritis. In my practice of 100 rheumatoid patients, there might be 1 or 2 who start with from only one joint, only from the wrist, or only one side wrist is affected. After 6 months, it may be some more joints may be added to the portfolio. So it can be monoarthritis by itself, or over the time it can progress to oligo or polyarthritis. Oligo means 2 to 5. So usually when you see 2 to 5 joints involved, you don't think of infection. So traditionally we have been taught that whenever there is a swollen joint or a tender joint, monoarthritis, always put a needle and to the extreme step, I have seen many patients with monoarthritis. There has been a cut. People have done biopsy. People are very interested or they want to solve this by doing a biopsy. But if you just give little attention that whether there is a small other joint is affected, because the knee joint in particular, I am talking the knee joint. When there is a young patient come with a knee joint pain, please, before putting your knife, which I have already discussed in SVNIRTAR in my last talk, before putting your knife, please take a family history. If the brother is also having similar kind of illness or the brother is having a back pain, it could be reactive arthritis. Please take the history of a past history of UTI, past history of past history of IBD or past history of diarrhea, or just search for another small joint or a history of uveitis. Most of the time, 90% of the time, you don't have to put a knife or a needle inside the joint. You can clinically make sure that this is a case of reactive arthritis. Then polyarthritis, more than 5 joints. If there are more joints symmetrical, most probably this could be rheumatoid arthritis, psoriatic arthritis. Again, if it is a polyarthritis, more than 10 joints, then the next is what is the distribution? Whether which joints are affected. Like if the peripheral joints are affected more, I'll show you the some cartoon diagrams to know that how distribution of the joints are very important in making a diagnosis. If the wrist is involved, the DIP are spared, MCP, PIP are involved, we know that this is rheumatoid arthritis. But if the wrist is not involved, then please think 90 times, 100 times before doing a diagnosis of rheumatoid arthritis. Although you may not find it written somewhere, this is my clinical tips. Don't diagnose rheumatoid arthritis if the wrist is not involved. 95% will be right. Because so many times I have seen psoriatic arthritis, although wrist can be involved also in psoriatic arthritis. But if the wrist is not involved, there is a more chance of the patient may be having something else like psoriatic arthritis, not rheumatoid arthritis. So my bottom line is, if wrist is involved, it could be anything. But if wrist is not involved, please don't diagnose rheumatoid arthritis. You will be correct in 98%. 2% you may be there may be wrist involvement at later stage. If axial predominant involvement, like your neck, back is more involved, then think of disease like ankylosing spondylitis or psoriatic spondylitis. If the neck is involved, back is not involved, please think of psoriatic arthritis ahead of ankylosing spondylitis or axial spondyloarthritis. And sparing some joints, like we know that usually rheumatoid doesn't involve the DIP joints. Usually only DIP joint involvement could be osteoarthritis or psoriatic arthritis, likewise. So distribution of joints tells us many things, and this point number 6 or step number 6 is very, very important. Then next important thing, what is the pattern of involvement? Whether this is a recurrent involvement or recurrent means episodic arthritis. Like when it comes to episodic arthritis, then the duration of arthritis is very, very important. We know that gout is episodic arthritis. So when it comes to episodic arthritis, please remember 3. One is palindromic arthritis, palindromic rheumatism. Usually 10% of the rheumatoid arthritis in their starting phase, they'll have only arthritis of one joint, episodic arthritis, which will last for hours to days, usually 7 to 8 hours, sometimes 1 day to 2, not more than 2 to 3 days. That is palindromic rheumatism. If it is from 5 to 7 days or 5 to 10 days, and whether you treat or don't treat, the disease will go away. Again, it will come after a month or 2 months. This is gout. If this is staying for more than a month, this is staying for 3-4 months, then it is going away. It is coming again after 1 year or 2 years. This is most probably reactive arthritis. So, what is the pattern of arthritis? If it is episodic arthritis, again, what is the duration of the arthritis? All these things, if you go step by step, you can have your final hunch that what is this arthritis that you are dealing with. Whether this is additive arthritis, like I have told you, many arthritis in spondyloarthritis or psoriatic arthritis, this one joint may be added after another joint. And again, I have told you migratory arthritis. like Lyme's disease, Lyme's arthritis is again another example of migratory arthritis. Not only the joint, then you have to, after step number 7, you have to come out of the joint and see, have a thorough checkup from the top to bottom, whether any extra articular symptoms are there or not. So many times we are not able to diagnose a psoriatic arthritis because we have missed psoriasis. The patient usually may not give you a proper history of psoriasis if we have specifically not asked for it. And many times there may be small patch at a very inconvenient site, like it can be the natal cleft, it can be behind the or below the breast, it can be in a in an area which is usually hidden, or the patient might have forgotten, patient might have not given any importance. So you have to check from top to bottom for any rash, any history of fever, any alopecia, any rash or skin rash. All these things are recorded, because if they are there, then this is most probably connected to a disease, or this is some other arthritis. This is not simple rheumatoid or axial spondyloarthritis. Step number 9 is any associated medical illness. Again, makes your life more comfortable. Like if it is a very typical rheumatoid arthritis pattern of arthritis, but many times I have seen the face and there is a leonine faces, or people have missed, there is a this lepra reaction kind of infiltrating skin rash which has been missed. So many times patient doesn't give a history of this anesthetic patch. You may miss a patient of lepra reaction, because lepra reaction can have a typical rheumatoid kind of illness. You can miss, if you have not taken a history of tuberculosis, then you may miss a Ponson's arthritis. A patient with a coexisting tuberculosis, if having arthritis, that is labeled as Ponson's arthritis, not rheumatoid arthritis. And rheumatoid factor may be positive in all these infectious arthritis actually. So associated medical illness is step number 9. And last is family history. I have told you what is the importance, because if a patient is having a knee joint pain and swelling, and if the brother is also having the same thing, or the father is having a history of psoriasis, then the diagnosis become very easy. So these are my 10 steps to glory. Please note it down. And if you go through this step by step, I don't think that anybody will fumble in their diagnosis, or at least 90% of the diagnosis you can make out without doing a single lab test. So identifying the correct pattern, because like in forensic medicine, we always believe that anything has happened or any incidents has happened, there must be a footprint. So identify those disease footprints correctly. Identify the exact key which will fit to this log, then I think there will be no problem. So like I was discussing, if you see this left side diagram, if these are the typical joints that are involved, with bilateral wrist is involved, there are bilateral MCP, PIP, lots of bilateral symmetrical joint involvement, both upper and lower limb, large and small joints, pairing the DIP joints and the axial spine, most or lumbar spine is mostly rheumatoid arthritis. Whereas another patient having multiple joint affection, but it is a lower limb predominant, oligoarthritis, large joint predominantly affected. Even if the small joint affected, this is called a ray sign. They are affected in a single joint, in a single toe. There may be dactylitis. So this is a feature of reactive arthritis or a psoriatic arthritis. You can have asymmetrical involvement of a single side sacroiliac joint. If you have your neck is not moving, back is not moving, mainly predominant or hip joint are affected, mainly axial joint involvement. This could be ankylosing spondylitis, or what we call today is axial spondyloarthritis. And the last is the joints that are overused in the body, like fast metacarpophalangeal joint, fast MTP joint, knee joints, hip joints, acromioclavicular joints. So these are the joints. If they're only involved DIP joints, then it could be osteoarthritis. So I'll show you quickly some of these clinical photographs. So this is a photograph. If the patient comes with this, our immediate clinical diagnosis will be rheumatoid arthritis, although it can be also mimicked by, like I have told you, lepra reaction, SLE, it can be viral arthritis if the acute onset illness, and so on. If you'll see mainly the DIP involvement with some nail changes, this is psoriatic arthritis. If you have bilateral knee involvement, it is most probably osteoarthritis, or there is swelling. It could be reactive arthritis. If a young patient comes with a single joint arthritis, so many times, I have again and again repeating this, so many times, sorry. Unfortunately, I have seen many of these, sorry. Many times I have seen that these patients are being unnecessarily put into surgery, unnecessarily done a biopsy. People have missed that some other joint is also involved along with this, some MTP joint or PIP joint, and these may be reactive arthritis, or if it is very red hot tender and the patient is having a big background, if it is a diabetic patient, if it is a patient who is on immunosuppression, it could be septic arthritis. So this is again a patient with a typical red hot swollen joint. You can see some chalky deposits in the right elbow, left elbow, which is coming out. So this is the patient of gout. Not only the joints, as I have told, you have to be a Sherlock Holmes. You have to be a detective to actually find whether you are missing any additional clue where the diagnosis may be totally changed 180 degree or 360 degree. Like a same patient looking like a rheumatoid arthritis patient, if having a palatal ulcer, could be lupus. The same patient, if having a history of diarrhea or having a typical ulcer in the leg or a skin rash, it could be a vasculitis and so on. So you have to examine, you have to take a history of constitutional symptoms like fever, weight loss. You have to take the, you have to examine the skin and mucosa, oral mucosa. You have to take the history of GI symptoms or a urinary tract symptom. You have to examine the eyes, take the history of any red eye. Sorry. You have to also see the any history of dry eyes there or not, and then you can. So you can see these are some of our clinical photographs taken in our lab, taken in an OPD. That this is a patient of discoid lupus. This is alopecia, carrying alopecia. This is one of my patient with lupus, who is having typical butterfly rash. This is a young gal with periorbital edema and came out to be juvenile dermatomyositis. This is a patient of scleritis and also having polyarthritis, which was diagnosed with rheumatoid arthritis. And a patient again typical like rheumatoid arthritis. When I look at the face, it was all tight and everything is, there is a huge loss of weight to the patient. The skins are very tight. The mouth opening is certain. This is Scleroderma. And this is a very interesting case actually, who has came and admitted in the oncology department with the cancer specialist as a history of polyarthritis and lymphadenopathy. There are small lymph nodes in the axilla. They have done a biopsy. It came out to be reactive hyperplasia. Then they called me that whether there is any autoimmune, to rule out any autoimmune cause of this fever. And when I have gone to the patient and just asked the patient to open the mouth, the diagnosis was written under the palate. And you can see the beauty of the palatal ulcer. This is very, 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 very typical of lupus. And if the patient gives you a history of blueness of the fingertips while exposure to the cold, this is Raynaud's. Sometimes may be difficult in appreciating in our patients. This is a patient of gangrene. If the patient, this is one of my patients with SL with antiphospholipid syndrome. But again, gangrene could be because of malignancy, gangrene could be because of vasculitis, gangrene could be because of thrombotic illness. So this is again another interesting patient who came with polyarthritis, but when I have seen the nail very closely, you can see what we call a thimble pitting. And this is a feature of psoriatic nail. And this was a case of psoriatic arthritis. You can again see that these are typical lesions of psoriatic arthritis, where you can find the lesions just over the extensor surfaces of the hand, extensor surfaces of the ankle and feet. So you can see another patient who came with, this is what is called as dactylitis. The whole finger is swollen. This is not only synovitis or arthritis. Dactylitis is a mixture of synovitis, tenosynovitis, inflammation, and subcutaneous edema, and everything is swollen in the joint. So that is what is called a dactylitis. And this is very, very typical of reactive arthritis, psoriatic arthritis, or gout. This is a patient of reactive arthritis, and this is the typical lesion is called as Scleroderma blenorizica. These are again another patient of reactive arthritis with having this pit cell also. This is called succinate balanitis. So you have to check all this, ask for all this. Otherwise, the patient may not come with the findings to you. This is another patient where you can appreciate the reactive arthritis patient. You can appreciate the subungual hyperkeratosis. You can see that just beyond the nail bed, there is a lot of keratosis, hyperkeratosis. And this is a patient of reactive arthritis. The same patient, you can see the Scleroderma blenozica kind of skin rashes on the sole and feet. Okay, this is another patient of HSP or Henoxylon purpura. So all the skin rashes, so you see they are almost looking like same, but this is a vasculitic rash, and this is what we call as erythema nodosum, because they are very painful. Erythema means red color and nodular lesions, which are very, very painful. If you find this, our diagnosis is whether this is a case of sarcoidosis, this may be a case of tuberculosis, or this could be because of leprosy, particularly if they are also in their hand, which we call as erythema nodosum leprosy. And this is again another patient of polyarthritis with severe lepra reaction kind of infiltrating lesion, and you can see the face, which is called a leonine faces or lion-like faces. These are patients of leprosy, lepra reaction. Another patient of polyarthritis, when we have done a chest X-ray, you can see frank pulmonary tuberculosis. So this was Poncett's arthritis. This is not reactive rheumatoid arthritis. And this diagnosis is very, very important, because if you wrongly diagnose this as rheumatoid arthritis and start giving methotrexate and steroid, there is a very high chance that the tuberculosis may clear. So rather than going to very high-fi diagnosis, diagnostic tests or very fancy test, once you have done with your history and examination, then please look through your the reports that the patient is carrying, the routine reports. The CBC report itself can tell you a lot of things. If there is anemia, this could be anemia of chronic inflammation. Sorry, it can tell you that there is a long-standing history of arthritis. It could be lupus. If it is hemolytic anemia, which type of anemia? If it is a hemolytic anemia, this could be lupus. This could be TTP. If there is associated thrombocytopenia. So if the TLC count is low, it could be SLE. If it is high, this could be vasculitis. If the platelet counts are low, it could be SLE. If it is high, it could be vasculitis. Or platelet count is also a marker of inflammation. If platelet count is 7 lakhs, 8 lakhs, don't get panic. This could be very high disease inflammatory burden. And ESR and CRP, we know that they are not very specific. Liver enzymes, you have to be very, these common things I am highlighting is what I call is as simple urine test should be done in all patients of arthritis, because particularly young arthritis, because if the patient is having a silent proteinuria, which the patient or the doctor is not aware, you may be missing a patient of lupus and you are treating as simple rheumatoid arthritis, and after some days, the patient may land in rheumatoid renal failure. Chest X-ray, if the patient is having some chest complaint. So CBC and urine routine microscopy, simple tests, they provide clues to suspect, enough clues to suspect connected to disease. ESR is not arthritis. There is a common proverb that tuberculosis can cause any time of presentation except pregnancy. But what I tell is that ESR is something can be elevated in everything, including pregnancy. So even in trimester, second, third trimester of pregnancy, ESR may be high. So ESR, although it is extremely sensitive among residents, that is my full form of ESR, we give very less importance to ESR. For us, ESR is not arthritis. This is a king of non-specific lab test. It's a very sensitive test for inflammation, but again, this can be increased in any infection, this can be increased in any inflammation. It can increase in malignancy. So don't go only by ESR and declare that this is inflammatory arthritis. So there are certain specific roles of ESR that if it is more than 100, this could be in an old lady who comes with shoulder pain and hip pain. This could be PMR, polymyalgia rheumatica, or giant cell arthritis. And ESR has a good role if you are treating a patient over time, and if the ESR is coming down, then you can think that okay, the patient most well is going towards remission. ESR more than 100 raises some possibilities of multiple myeloma, giant cell arthritis, tuberculosis, and Still's disease. Again, another very fancy and very common test, ASO. So ASO is actually not a inflammatory marker test, or this is actually not a test to tell that this patient is having acute rheumatic fever. And acute rheumatic fever, the incidence has become so low because during our MBBS days, usually any patient coming with arthritis is usually being advised as for ASO, and if ASO is positive, then usually subjected to penindior injections, which is very can be tricky because penicillin can kill a patient. So acute rheumatic fever is very rare nowadays, particularly after improvement in our basic sanitation and basic hygiene status. And usually in a child, if you are suspecting, that is okay. And this present with a very typical arthritis. This is anybody coming with a small joint arthritis, symmetrical arthritis, please don't diagnose. Even ASO is high, don't diagnose as acute rheumatic fever. Usually the pattern of arthritis is asymmetrical, and this is migratory arthritis and very painful arthritis. And this is usually the common saying by my teacher that how to diagnose Still's disease or juvenile JIA, systemic onset JIA from acute rheumatic fever. Acute rheumatic fever child is usually a sick child. Usually patient is of so much of pain that usually patient get admitted in the hospital. But systemic onset JIA is only symptomatic for 2 hours when the fever peak is very high. The other time, the child may be playing with the siblings very comfortably, going to school, everything, but in the night only the patient is having that episodes of fever, or what we call as quotidian fever, and feeling very sick. So these are the silent clinical points. Large joint affected. Usually the acute rheumatic fever affected the knees, the ankles, the elbow, and the wrist, big joints, not the MTP or MCP joints. And usually if you give a course of ecosprin, high dose of ecosprin, or nowadays the Harrison textbook says that if you give plain naproxen tablet 500 twice daily, and within 3 days the patient arthritis is not improving, pain is not improving, most probably this is not acute rheumatic fever. So overdiagnosis means unnecessary penicillin injections, and believe me, penicillin injections can kill. That we have seen during our MBBS days, that penicillin hypersensitivity for a wrong diagnosis can kill a patient. So please be aware before giving a diagnosis of acute rheumatic fever. Increase uric acid, again another very common fancy test, that any child come to your clinic with arthritis, prescribe uric acid, which is not correct, because usually gout occurs only to male. It doesn't happen below or before a woman attained menopause. So if you are prescribing, or if you are thinking gout in a case of male which is less than 30 years or 40 years, or a female which is less perimenopausal age group, then you have to be very careful, because usually children doesn't suffer from gout. I'll tell you about the 5 aphorisms what Hippocrates have told long ago. If you remember those things, then you can make gout in most of the cases without doing any tests. And it is usually diagnosed from history. Again, why it is so important to diagnose gout in first place? Because if you give Uric or allopurinol without having a proper diagnosis, allopurinol can kill a patient. I have seen 4 or 5 cases of severe allopurinol hypersensitivity. So gout doesn't kill, but allopurinol hypersensitivity, or the tablet given for a wrong diagnosis of gout, can kill a patient. It can cause severe Steven-Johnson syndrome, or 10 kind of thing, or dress kind of skin illness, and if not given proper attention, patient may die. So how I diagnose gout? The most famous physician, Sydenham, who himself was suffering from gout, he has described his own feeling, which if you understand and remember, I think the next time you see a patient of gout, you can ask this history. That the victim goes to bed and sleeps in good health. About 2 o'clock in the morning, he is awakened by severe pain in the great toe. More rarely, it can be not only in the great toe, sometimes it can be in heel, ankle, or instep. And the pain is like that of a dislocation. So many times I have seen patient come with a wheelchair in the first attack, and people have done MRI or X-ray thinking that this could be a ligament sprain or this could be a fracture. This is the he has described his feeling. This is just to tell you about the dramatic onset, that the parts feels as if cold water was poured over them, or something is violent stretching, tearing of the ligament, gnawing pain, or pressure of tightening. It is so much so that he was not able to bear the weight of bedclothes, nor the jar of anybody working in the room, and the night is spent in the torture. So this is the language of a patient who is a doctor himself, famous doctor, his own words. So how to diagnose gout? In my words, gout is kind of tsunami. I always ask the patient that whether you had a history of tsunami or not. What is tsunami? That a very abrupt onset comes without giving you a notice, and whether you treat or not treat, after 5 days, 7 days, it will go away very calmly, like it has come, without leaving any further pain or footsteps. So diagnosing gout is abrupt onset, severe pain, swelling, redness, or tenderness. Maximum, the peak of pain is within 12 hours, 24 hours, improvement by 5 to 7 days. Many times the patient tells, sir, I have taken these painkillers, then only the pain has gone. Believe me, even if the patient will not take painkiller, it is an episodic disease and it will go away within 5 to 7 days. Most of the times, 90% onset is monoarticular or single joint involvement. And 50% of them usually start with the first metacarpophalangeal joint, metatarsophalangeal joint or MTP joint. And a presumptive diagnosis for this typical attack of gout, if it is a typical attack on the first MTP episodes of, there is a history of similar episode, abrupt onset, severe pain, pain relief within 5 to 7 days. If you write the diagnosis without doing a uric acid, if you write the diagnosis gout, 98% will be right. Coming to rheumatoid arthritis, again, positive rheumatoid factor is not rheumatoid arthritis. Rheumatoid arthritis factor or anti-CCP for itself, they are not important for diagnosis because 30%, 1/3 of the patient can be seronegative. So why you have to do those tests? Only to give a prognostication to the patient that if you have a high titer of anti-CCP or high titer of rheumatoid factor, most probably the patient can have a aggressive disease, more bone erosion. So you have to start with the disease modifying agents from the very beginning. And after the age of 60, 70, many of the normal person can have these autoantibody positive because normal healthy population, usually the incidence of positive rheumatoid factor is 5%. But if it is a old lady or old man, then 10 to 25% it can be normal. So no value of repeating rheumatoid factor once positive. I have seen patient every time comes with a rheumatoid factor report. But once you are know that this patient is having a high titer of rheumatoid factor, the diagnosis is made. There is no further value in repeating it again and again. Although you can repeat it twice if you are strongly suspecting. Sometimes you may repeat it after 3 months or 12 weeks because they tell that 2 times at least it has to be repeated if you have a strong diagnosis of rheumatoid arthritis, but not every time the patient comes like ESR and CRP. So this is the new criteria. Again, in this new criteria, you will see there is very less importance has been given to rheumatoid factor and anti-CCP because out of 6 points, only if you have a typical joint distribution, you can have 5 points. If you have a symptom duration of more than 6 weeks, you can have 1 point. 6 points has been made. If you have a ESR CRP elevated, again another point. So without a rheumatoid factor anti-CCP, you can very well meet the diagnostic criteria for rheumatoid arthritis. Okay, so I think we are going late. So this is I am telling again and again some facts because these are very, very important. Again, because rheumatoid arthritis is a very, very clinical diagnosis, there are 2 basic fundamental requirements before making this criteria because more than 10 joint, even a fibromyalgia will fulfill the diagnostic criteria for a rheumatoid arthritis. But patient should have a one objective definite sign of clinical synovitis. That means you should clinically demonstrate that this joint is definitely swollen. Then only you can put the formula rheumatoid arthritis and you will not misdiagnose fibromyalgia as rheumatoid arthritis. Synovitis is not better explained by another disease. Like I have shown you in the my discussion that lepra reaction can have a typical arthritis pattern like rheumatoid arthritis, and it will try to fulfill the diagnostic criteria. SLE, lepra reaction, TB, Ponset arthritis, vasculitis, everything will fulfill the arthritis of rheumatoid arthritis. So that's why the differential diagnosis you should be able to differentiate them out that there is no psoriasis, no skin lesion, no history of arthritis, no history of IBD. If still you are not able to do that, or if still have doubt, the diagnostic criteria typically, if you are unclear about the relevant differential, an expert rheumatologist should be consulted. because in our rheumatology practice, every day in and out, we try to figure out this, what is rheumatoid and what is not. So just to the last, I'll discuss a case which is very, very pertinent to our discussion of clinical approach to arthritis. This is a case of knee swelling. You can see that very well. There is a swelling in the suprapatellar pouch. This 22-year-old businessman, right knee swelling for 2 months, difficulty in walking, admitted in hospital. So first visited to a orthopedic center, synovial fluid aspiration has been done, and no conclusive information shows synovial biopsy has been advised and it is done. And the biopsy report shows, these are the reports, you can see the TLC count is almost normal, the ESR, CRP are normal, and uric acid is mildly high. But the histopathology report is clearly showing that the features are suggestive for rheumatoid arthritis. Actually, I'll tell you, rheumatoid arthritis is a clinical diagnosis. Again, no biopsy report can tell you that this is rheumatoid arthritis. Biopsy report can tell you that there is feature of inflammation. There is a dense acute and chronic inflammation. But it is very unfortunate that it will put, so it should have written that the feature suggestive of inflammatory arthritis. If you write rheumatoid arthritis, most of the time this is taken on the face value and patient immediately started on treatment of rheumatoid arthritis. So that's how the patient came to me. And you can see the synovial culture is normal. The finding is suggestive of rheumatoid arthritis. But when you can see the biopsy mark on the left side, when I have reviewed the history, I have got the history that the patient has a typical UTI 5 weeks back, the brother has an inflammatory back pain. There is never any history of wrist and hand joint, and as I have highlighted, if there is no wrist pain, please don't make a diagnosis of rheumatoid arthritis. You will be 98% correct. So the diagnosis changed to reactive arthritis, and I think this biopsy in this patient could have been easily avoided if we have done this background checkup and we have taken the history properly and examined the patient. So these are interesting recommendations by the American College of Rheumatology that don't order autoantibody panels or these fancy tests on without any proper evidence of rheumatic disease in your clinical pattern. Don't repeat do ANA by ELISA method. Don't do ANA profile if you don't, your AN is negative and so on. And most relevant is 90% of the cases, if you are asking for a back X-ray or a spine X-ray, that maybe you don't need it actually. You probably don't need an X-ray, CT scan or MRI in 90% of the cases. So to finish, to conclude, 80% of diagnosis from history, arthritis profile creates confusion. If you have not taken a proper history, if you have not done a thorough checkup or examination of the patient, only sending a profile testing will put you into more confusion rather than clarity, because many of these tests can be positive in normal individual. Many of these tests may be negative in a typical case of rheumatoid arthritis or a reactive arthritis. Plain investigations like CBC, complete blood count, and urine maybe get to diagnose connective tissue disease. ASO, uric acid, rheumatoid factor, they are not the test for polyarthritis. ESR and CRP, somebody is high, it denotes inflammation, but it doesn't tell you that there is arthritis or connective tissue disease. Be aware of false positivity of autoantibodies. Don't fall into the trap, because ANA, rheumatoid factor, everything may be positive in a case of fibromyalgia. So immunological investigations often create confusion instead of offering solution to the diagnostic problem if it has not been advised in a proper context. So rely more on the stethoscope or on your diagnostic intellect or a proper history taking, proper examination method, rather than only doing or chasing the blood test or microscope. So rely more on stethoscope than microscope. That is my bottom line. And this is one of my patient who was suffering from rheumatoid arthritis, shared me these photos before her marriage. She was so glad because 3 years back, she came to me in a very, very bad condition, all joint involvement. She was almost unable to do anything. She was an IT professional, but after a proper treatment, and now she's only on methotrexate 15 mg and folic acid, nothing else, and she's going to marry and have a family. So thank you very much. I think, hope I have taken a little bit of extra time, but hope you all have enjoyed this. So over to Pavitra sir.
Thank you. Thank you very much, Dr. Professor Jyoti Ranjan Parida. Excellent lecture. You have your algorithm and presentation definitely will help all our students to have a basic idea that how to approach arthritic patient in clinic. So algorithm is really eye-opening algorithm. So I hope all our students, all our participants, they must have a clear idea about how to approach patient with arthritis in clinic. And so it's already 8:45. So I think we'll have to close the session. Before closing the session, I must thank you very much, Dr. Jyoti Ranjan Parida. You have taken my accepted my invitation. Rather, whenever I requested you, you have taken many classes in our department also, and really we are grateful to you that whenever we are seeking your help, you are always agreed to help us. And I hope that in near future also we'll expect some more lectures from you on other forms of arthritis.
Thank you, sir. Thank you for your all kind words. And I always feel that arthritis treatment is a teamwork. So many times I also need the help from your side, because the final aim and objective of all of us who are involved in patient care actually for the betterment of the patient. So there should not be any kind of feeling if I need any help from my professional colleague at any point of time. I think we should all work jointly so that we can make the life of these patients from hell to make them a better life. Because now all of us has understood actually most of these patients that we have seen in our old days could have in a state of actually they could have been reversed actually. So now the time has come actually for a joint work. I think that is the most appropriate word. And thank you all of you for your kind invitation. And I'm so happy when I meet people from NIRTAR or like some of my known faces that you always welcome me with so much of what I'll tell with heart and this thing. So thank you everybody for your patient listening.
Can you have one or two questions to
Yeah. I have time. You can ask one or two questions.
One question from participant side: what will the plan of management for those female who are on methotrexate for RA if they plan for conception?
So very relevant question. Like I have shown you in my last lady who was about to marry, and with that Mehendi picture. So ideal period is before planning for anything in a inflammatory disease has to be planned. So you have to tell that patient that you can marry, you can have a career, you can have children, but everything has to be planned in advance. So if first before going for conception, you have to see that the patient is under control. Once the patient is in remission, then try to change your medicine from methotrexate to sulfasalazine, hydroxychloroquine, which are safer in pregnancy. Because if you stop the medicine altogether, there might be a flare either in the pregnancy or in the postpartum period. So usually 6 months is the ideal time period. But even if the patient is in a hurry or already the age is late, so 3 months is sufficient enough. So 3 to 6 months, you have to stop methotrexate. What you can continue during pregnancy is hydroxychloroquine, sulfasalazine, and if the patient is symptomatic, low dose steroid like 5 milligram, 2.5 milligram is also okay. No painkillers. NSAIDs are absolutely no. No painkillers, no methotrexate, lepronomide obviously no. And most of the drugs are no. Biologics like adalimumab and this thing, they are coming as a safer alternative. Like recently I had experience of some of my patients, rheumatoid arthritis, reactive. They are severe pain during 6 months of pregnancy. And adalimumab has done a wonder because those are coming as a safer alternative. Not all, but many of them has been now got their clarification for being used in pregnancy. So now we have more, gradually we have more treatment options also to treat the patients, keep them in remission during pregnancy.
Okay, one more question. Is it true that pregnancy cures RA?
So first of all, pregnancy is not a permanent state of affair. Pregnancy is only for 9 months. The natural history of rheumatoid arthritis is Usually, most of the patients may go to remission during pregnancy, but there is a high chance of flare. It is not curing. It is the rheumatoid arthritis goes to a state of remission. It requires less of medicine during pregnancy. Not in all, in majority cases, that is true. But all those patients usually flare up or bounce back during the postpartum period when the patient is taking breastfeeding or just after. So 3 to 6 months after pregnancy, again the disease comes back. So you have to be very, very careful to keep the disease under control. So most of the rheumatoid patients have low disease activity during pregnancy. That makes our life a little easier. Yeah.
Okay. What is the role of IUC in CTD and RA?
IUS means our alternative medicine system.
AYUH. What is that? AYUH?
Most probably IUS means you are talking about alternative medicine like Ayurveda and Unani and homeopathy. No.
AYUH. I don't know who is raised this question. What is the role of AYUH in CTD and RA?
Yeah.
So question is not clear.
Oh, it is IUS.
It is IUS. Yes.
Okay. So see, like I have told, it should be all joint involvement for disease control. It is not that allopathy is great or Ayurveda is great. In allopathy also, you must be seeing that there is nothing called allopathy. It is all evidence-based medicine, that how you are trained, how you are for treating a patient of arthritis. The problem I use till now to me is, I have interacted with so many people from different spectrums and this thing. Unfortunately, most of the diagnostic criteria and most of the evidence-based things have not come in alternative medicine. That is what is my personal feeling. Most of the time, we treat them as based on this uric acid level or as in a single basket like rheumatism. So that is my thing, that I think we have to wait to see result of ICE, and the time has come that most of the treatment that we are giving in ICE and this thing should have a strong evidence backup.
Yes, exactly.
Without that, we cannot accept anything, because as I have told, there is a window of opportunity of 1 to 2 years. We cannot spoil the time of the patient just trying treatment from one another. Number 2 is whatever branch of medicine you treat, the diagnosis has to be correct. Number 2, whatever treatment you give, there has to be hundreds of scientific paper suggesting that if you give the drug, this is how you should monitor, this is how you should treat, and there should be algorithm fixed. If the patient is improving, you should go like this, you should go like that. That is only my contention for ICE.
Okay, thank you.
I think it is all related to that. Yeah.
Yes. Thank you very much. I hope there is no more questions from the participant side. So in that situation, we should now conclude the session. Thank you very much, Professor Jyoti Ranjan Panda.
Thank you all once again for inviting me and making me a part of this evening. Thank you all.
Okay, thank you all participants.
Hello, thank you, sir. Hello, I am Dr. Ambalavan, Physiatrist, practicing in Chennai, Savita Medical College Hospital. And very, very nicely presented presentation. I joined lately, but I enjoyed. And I want to, share my experience. I traveled internationally, worked in Middle East, and rheumatoid arthritis and connective tissue disorders are very common, especially gout in Middle East, because they are more meat eaters. And their own medicine called Islamic medicine was picking up very much. The same thing that I would like to suggest our colleagues to do more research and evidence-based in our own Indian medicine, like Ayush. In Chennai and down south, the Siddha is from southernmost part of India, and our sages developed that medicine. And unfortunately, I went and saw the buildings and the medicine and the inpatient facilities are in very bad shape. I really want all our physiatrists to stand up and support our medicine, and also support our government, insist our government to support this traditional medicine of our culture. And we should stand up and say our medicines are less side effects than the allopathy. And this is my wish. And I really thank the organizers, and I really thank the speaker who enthralled his presentation, very nicely presented. and beautifully conveyed the message in a very nice and simple manner. Thank you, sir.
Thank you. Thank you very much,
Thank
sir.
you, sir.
So thank you all participants for joining this webinar. And thank you. I must thank all the office bearers of IAPMR, the PR team, all my colleagues from Department of PMR, SVNIRTAR, and all the members of Odisha Association of Physical Medicine Rehabilitation for supporting and for organizing this type of webinar. We hope that we'll continue this webinar with a number of good talks with the experienced people, experienced academicians, and much more. Thank you very much. Thank you all.
Sir, finally, one word. You're most welcome to our part of our medical college. We have a lot of space and we can organize a combined scientific session symposium to our place. I welcome you all.
Sir.
I welcome you all. You can plan, and we have lots and lots of things going on here in our college.
Sure, sir. Thank you.
Thank you so much. And please give us the recording or send us the PDF font of the professor's presentation.
Sir, this presentation is available on the YouTube mode. Anybody who has missed this part of the presentation can go through the YouTube mode. Our PR team of IAPMR, they are organizing and they are making it available on the YouTube also. At any time you can go through this presentation.
Very nice, sir. Great going.
Thank you very much, and good night, everybody. Thank you.